today's session, Every Code Tells a Story. How to bolster clinical documentation accuracy and success, sponsored by Civista. On behalf of Becker's Healthcare, thank you for joining us at our CEO and CFO virtual forum. Before I introduce today's panelists, I would like to go over a few housekeeping items. You'll find a few engagement tools on your dashboard. Please submit any questions using the Q&A box and be sure to check out our resources section and fill out our event survey. This session is being recorded and will be available on demand following today's event. We will send you instructions on how to access the on-demand recordings once the event concludes. At this time, I am pleased to introduce our presenters. Nicole Newman, Clinical Documentation Integrity Coordinator at Civista. Colette Zayor, Health Information Director at Civista. And Lori Fiore, General Manager of Client Middle Revenue Cycle Services at Civista. With that, Lori, I'll turn the floor over to you.
Hello and welcome to today's program, Every Code Tells a Story, how to bolster clinical documentation accuracy and success. For more than 30 years, Civista has been solving problems and providing positive outcomes for acute and ambulatory facilities and systems through revenue cycle management services. Our vision is to improve the business of healthcare and empower providers to enrich the quality of their patients' lives and nurture their communities. Our agenda today will begin with a discussion on how an effective CDI program can improve your organization's quality measures. Then we would like to highlight the successes a Civista client experienced as a direct result of a quality-focused program implementation. Integrating clinical quality-focused CDI reviews into an existing DRG-based program is vital to improving your organization's quality measures. Let's begin with looking at what CDI is. As you know, clinical documentation is the process of recording the care delivered to a patient by the care team. Clinical documentation integrity is when a specially trained nurse reviews the medical record for conflicting, incomplete, or non-specific information. Laboratory and diagnostic test results, imaging, patient vitals, medications administered, services delivered, symptoms, interventions, and the patient's response to treatment are all part of the review process. The goal is to ensure a complete clinical picture is documented to accurately demonstrate the complexity and quality of care the patient received. So why is CDI important? Coded data obtained from clinical documentation is vital to a healthy patient and a healthy revenue cycle. It reflects hospital quality and perception regarding care, as well as determines incentives and payments. It even impacts selection of a correct patient status and length of stay. Accurate clinical information provided to SNFs and other long-term care facilities is essential for appropriate patient placement and reducing the risk of readmissions. In addition to accurately reflecting the quality of care to your patient population, incentive payments, improving admission status selection, and reducing length of stay, denial avoidance remains a high priority for every CDI program. Coding, medical necessity, and clinical validation denials make up 80% of the denials exhibited in this slide. Integrating clinical quality reviews in your CDI workflow is a necessary additional component of your CDI program, not a replacement. DRG optimization and denials avoidance still require the same attention. Later in this presentation, I will provide you with information on measuring the level of success of your existing CDI program and metrics that should be reported regularly. The data in this slide represents how quality incentives and penalties impact healthcare in the U.S. Total penalties in 2020 equaled $970 million. 32% of hospitals received incentive payments, while 68% of hospitals paid penalties. The average dollar impact per hospital was $282,000. So who is reporting your data? Public reporting, value-based purchasing, physician and hospital quality relies heavily on coding. Even though many coders have acquired vast amounts of clinical knowledge, they need the clinical expertise of a clinical documentation integrity specialist to ensure the integrity of the documentation within the record so it can be correctly coded and the organization's data is reflected accurately. The attributes of a successful CDI program depend upon the integration of people, processes, and technology, all working together to ensure success. In the previous slide, you saw just some of the entities that are looking at and assessing your data. Data is now your organization's single most important asset. CDI alone cannot accomplish this. Executive leadership, directors of quality, IT, HIM, utilization review, and case management all need to be aligned to protect this valuable asset. Be aware that delays in documentation, such as consults, testing results, query responses, operative reports, pathology reports, and discharge summaries can inhibit the CDI's specialists' ability to obtain accurate information from all members of the care team. The lack of expeditious documentation also inhibits the concurrent reporting and mitigation of hacks and patient safety issues to the clinical quality team. We can use the example of a bank. As a commercial customer, I would have an expectation that all my banking information is current and accurate so I can effectively run my business. So not only is expeditious documentation and access to information critical to the care of patients, it is critical to a hospital's business operations. As a first step, consider a review of diagnostic testing result turnaround times for inpatient and observation patients. Physicians can't document what they don't have. In addition to coordination of people, processes, and technology, solid analytics and improved workflow are important elements of success. CDI managers should be cognizant of industry benchmarks. Ongoing education from both the clinical and coding teams should be provided, along with interactive DRG reconciliation processes. Audits of the CDI and coding teams, including the quality of their queries, should be ongoing. And in today's world, a CDI coordinator role to specifically conduct clinical quality reviews is recommended. As you can see, hospitals are losing 3 to 5% of their revenue each year, due in part to insufficient clinical documentation. Contributing factors to that are suboptimal value-based outcomes, loss of accreditation, lower case mix index, penalties for hacks and readmissions, increased cost to collect due to appealing clinical denials, and negative perception and decreased market share. As you can see, there are also other impacts with skewed public health data and inadequate documentation of severity of illness and risk of mortality. Next steps to enhancing your CDI quality focus are: number one, support from the executive leadership team. 2, evaluate the current state of your CDI program. 3, define the right process, people, and technology for operationalizing your health system's CDI program. Identify the need for CDIS trained for quality reviews, a CDI quality coordinator role. Establish an interprofessional approach between CDI, clinical quality, and coding. And educate providers, CDI specialists, coders, and other clinical professionals and determine performance measures for integrated CDI programs. Speaking of performance measures, how do you gauge your current level of success? There are different levels of success when it comes to a CDI program. Where are you in this spectrum, and how do you move forward? This tool can help identify performance gaps in order to move to the next level. We all know there are metrics to a traditional CDI program, but we wanted to include metrics for establishing a quality dedicated program and role. Colette, as the leader of the project for this case study, can you identify where you started in the model above and where you are now?
Yes, thank you, Laurie. Before the program started in 2014, we were reactive. Over 3 years, the program matured to a level 4. Let me tell you about our client hospital demographics so that you can compare it to your organization. It is a 407-bed acute care facility and a teaching hospital. It's providing brain and spine care, cancer care, heart and vascular, primary care, surgery, and women's health. The payer mix consists of 62% Medicare and Medicare HMOs, 26% managed care, 9% Medicaid, and 3% self and other pay. Out of all the hospitals in the state, the client organization rated number 1 in quality performance. We were in the minority in that only 12% of hospitals in 2020 received incentives compared to 73% with penalized. To name a few of the awards and accolades our client has received for quality performances are designated number 1 in the market by CareCheck for overall hospital care, overall medical care, and 9 specialties. Ranked number 1, CareCheck for overall hospital care and 4 specialties. Ranked in the top 10% of all hospitals in America by CareCheck for overall hospital care, overall medical care, and 9 specialties. Number 1 hospital in the region to earn the heart failure accreditation by American College of Cardiology, grade A, and patient safety by Leapfrog. CMS 4-star rating, the region's highest rating. However, this has not always been the case. In 2013, our journey began when our client received a C safety score from Leapfrog. It became the impetus for the clinical quality team to collaborate with Health Information Management to create the CDI quality program role. As you can see, our client has gone from a C score to an A. The client's goals were to improve the quality score by reviewing data reported, aligning the clinical quality measures and coding guidelines, prepare for risk and advanced payment models, improve the CDI processes, and monitor denial prevention. In order to fulfill the client's goals, there needed to be a subject matter expert on quality reporting and HIM. In addition, the person in this role would need to possess a high degree of clinical and coding knowledge. Consideration of how to leverage technology was a must, as this person would be collecting, reviewing, and managing quality data to successfully improve the client's outcome. This was the foundation to establish the CDI Quality Coordinator. Now, Nicole Newman will elaborate on this role and share with you the outcomes of our client's success.
Thank you, Colette. I will provide more details on the CDI Quality Coordinator role and a few but substantial successful outcomes this role has contributed to our client. Remember that much of a healthcare system's quality scores derive from claims-based data. The CDI Quality Coordinator is a gatekeeper, so to speak, justifying the ICD-10 codes that leave the health system, ensuring accurate reporting that mirrors provider efforts and the complexity of patient care. Consumers of healthcare, CMS included, use this data to make better informed choices when seeking healthcare. The CDI Quality Coordinator connects the three areas you see on the screen: financial, health information management, physicians, and clinical quality. It is imperative for these three areas to work together to maintain the highest level of quality possible. While CDI does incorporate quality indicators into their encounter reviews, they do still need to build a solid working DRG representative of the patient's acute and chronic comorbid conditions. This is so important to severity of illness and risk of mortality, HCCs and risk adjustment, which are all vital to a quality-driven program. CDI has daily productivity standards to meet and cannot perform deep dive audits in population-specific documentation samples. But the CDI Quality Coordinator does a 100% focused review. This can take a great deal of time, as the record in many cases needs to be scrutinized. With the separation of roles, this can be done without CMI interruption. With the advent of CDI Quality Coordinator, there was an opportunity to perform deep dive audits to solve higher level documentation issues. Partner with information technology to build business intelligence reports to track coded complications and distribute to interdisciplinary stakeholders. And I cannot stress enough the need to break down silos and have your CDI Quality Coordinator incorporated as part of the clinical team as a documentation and ICD-10 coding subject matter expert. This slide always motivates healthcare executives. For our client's organization, you can see the amount of revenue at stake. If you're a larger organization, the dollars at risk only increase. Now let's start with reviewing our client's hack data. Since the inception of the CDI Quality Coordinator program, the organization has not received a penalty for hospital-acquired conditions. This has been possible through interdisciplinary collaboration and executive leadership support. Let's review our client's value-based purchasing as it compares to their competitors. Value-based purchasing is based on three factors: safety, readmissions, and hacks. In addition to receiving a leapfrog score of a C in 2013, our client also received a penalty of a negative 0.319% in value-based purchasing from CMS. In 2014, after the inception of the CDI Quality Coordinator role, there has been an upward trend towards incentive versus penalty for our client. And this is unlike other facilities in their market who are maintaining an inconsistent trend, demonstrating the lack of high-performing program. And now let's review our client's readmissions as it compares to their competitors. As demonstrated here, the client has been able to mitigate impacts of readmission, unlike their competitors whose trends are inconsistent. Generally, the financial risk is over the $1 million mark, and this slide does not include risk adjustment, so that you are aware. Our client's results reflect the impact of the CDI Quality Coordinator. This role really does so much to bring together clinicians and administrators to supporting ongoing positive financial and patient outcomes. Here's our tool again. Use it to measure your organization's current status and consider establishing a quality dedicated CDI role which has been the key to our client success. This is how you can ensure that your quality story is accurate and reflects the value of your organization to consumers of healthcare. And now I'd like to take the opportunity to answer a few questions, if there are any from the audience.
Yes, Nicole, there are a few from the audience. The first question is, what applications do you use to monitor quality outcomes for your organization?
Thank you, Colette. Well, we use the electronic health record and the business intelligence reports that it produces. We also use some of the government software, AHRQ software, which tells us and scrubs the data and gives us the PSI information. And there's a myriad of other technologies that we use, but we do rely heavily on our business intelligence reports.
Our next question, how does the clinical documentation integrity manager handle a coded complication?
Well, the CDI coordinator really needs to possess clinical and ICD-10 coding acumen and review the medical record thoroughly, reaching out to the providers through discussion and the documentation query as well.
Our next question, how do you find someone for this role?
And typically this is an experienced CDI nurse who possesses clinical and ICD-10 coding knowledge. They have strong leadership skills and interpersonal skills, someone that's confident enough with their clinical judgment to question a physician and a quality director, someone that will engage with clinical quality team and build positive relationships with them. And this is so important when handling quality related issues that require reporting. Like I said, you have to have that clinical confidence to really approach the clinical directors, the physicians, surgeons, because sometimes the definition of a condition or a complication is different in ICD-10 terms than it is in clinical terms. And that needs to be demonstrated to the clinical team.
We have one last question, Nicole. How do you engage physicians and provide the necessary education to improve the quality outcomes?
Well, first and foremost, I always approach from a quality perspective. Physicians seem to be, and surgeons seem to be a competitive bunch, and they really do give it their all. They're trained, they want to do a good job. And to have quality scores that don't reflect what they really believe, the type of care they're really giving to their patients, they want to improve that. And so I always take an approach by mentioning quality and educating them on, how can we improve your documentation so that it's translated into the correct ICD-10 codes reflecting the correct care that you're providing for your patients. We also have an excellent and very involved physician champion, and really building relationships with the clinical quality team. Usually a service line, each service line has a representative from quality. Typically it's a nurse. And so, you really form relationships with them, because especially in a remote type of situation, you really need to rely on those quality nurses to personally approach the physicians or surgeons and discuss any of the issues that need to be discussed so that we can get clarification for documentation and ICD-10 coding and reporting purposes. Are there any more questions, or do we not have any time?
There are no more questions, Nicole.
That is all the time that we have for today. I did want to take the time to say thank you to Nicole, Colette, and Lori for the excellent presentation, and to Civista for sponsoring today's session. Enjoy the rest of your day and stay safe.